When entering the room, stop at the foot of the bed and observe the patient for about 5 seconds, assessing the severity of the patient's situation. Assess how sick the patient looks and level of consciousness. Look for cyanosis, pallor, flushing, and diaphoresis. If the patient, for example, has cyanotic lips or is sweating a lot, the condition is probably severe and you need to move fast. Finally, assess how hard the patient's work of breathing is. Is it very strenuous? Does the patient look weak, or is the patient hardly breathing at all? Doing this rapid assessment will help you judge how aggressively you need to treat and how fast. Acute asthma, for example, can be mild with requiring only an inhalation or two, or it can be life-threatening, requiring several inhalations and ventilatory support. When you gain more experience, the rapid assessment need only take one look, but use the time now to look closely for all these signs before proceeding. After the rapid assessment, present yourself to the patient and the treating team, and take a focused history from either the patient, relatives in the ED, or the ED nurse. Ask a few high-yield questions to get an overview. Onset of symptoms, pain, severity, and how long the condition has been going on. If need be, the assessment and treatment can be performed while taking the history. The focused physical exam of respiratory problems consists of 4 elements: inspection, palpation, percussion, and auscultation. Before starting the exam, remember to check and assess the airway, and if need be, administer oxygen. Start by putting the patient in a seated position. Undo any clothes so you can see the thorax. Look for cyanosis, flushing, or pallor. Look to see if the movements of the chest are equal, and look at the work of breathing. Is the patient using accessory muscles, like in the neck? Are there retractions, especially in children? And paradoxical respiration. Is the respiration sufficient, or is the patient tiring out? Also look for any signs of trauma. Feel along the ribs and the thorax. Feel for broken ribs and other signs of trauma. Also feel for subcutaneous air. It feels like snow creaking beneath your fingers and can sometimes be heard as well. From a sitting position, lean the patient forward to expose the back and tap the skin above the lungs from bottom to top. Listen for dampening or hyperresonance and remember to compare with the other side. If the patient is very ill, percussion on the back may not be possible. Instead, one can tap the anterior thorax with the patient in a supine position. Again, have the patient sitting and leaning forward. Listen with the stethoscope from top to bottom and compare with the other side. Listen for rhonchi and crackles. Absent breath sounds on one side may indicate pneumo or hemothorax. Remember also to check other organ systems, as they could give you vital clues to why the patient is short of breath. Check the heart for murmurs, the abdomen for pain and rigidity, and the extremities for signs of DVT. Most of these will be covered as you progress with your ABCDE assessment. Get the O2 saturation, an ABG, and a chest X-ray. These will provide good information on which you can base further testing and treatment, as well as a baseline to monitor progress. Depending on the soil situation, order blood tests, complete blood count, chemistry, coax, cardiac enzymes, and blood cultures. When treating respiratory problems, delivering medication directly into the lungs is often the quickest and most effective way. Nebulizer systems come in many types. In Denmark, we use a nebulizer system built into a Hudson mask, with medication coming in small plastic ampules. When setting up a nebulizer, take the mask and open the chamber, pour in an ampule of medication. Then close the chamber and turn on the oxygen or airflow and place the mask on the patient. The nebulizer mask requires a flow of 6 to 10 liters per minute, optimally 8 liters per minute for the right droplet size. The mask can run on oxygen or pressurized air. If the patient requires supplemental oxygen but a flow of 8 liters per minute is too much, as in COPD patients, the mask can run on normal air and oxygen can be supplemented with a nasal cannula. Most patients with shortness of breath will require oxygen supplementation. Depending on the severity, you have several options to choose from. When giving supplemental oxygen, you are essentially raising the fraction of inspired oxygen, FiO2. When breathing room air, the FiO2 is 21%. When administering oxygen, connect the tube to the oxygen tank or wall-mounted outtake and set to the side flow. Then place the device, nasal cannula or mask, on the patient. A nasal cannula is for patients who require a low supplemental flow, providing an FiO2 of 25 to 50%, but it is unpredictable. The nasal cannula can take a maximum flow of 5 liters per minute. Anything above that and it will not stay connected. High flow cannulas do exist, but if the patient requires a higher flow, a mask is a better option. A Hudson mask is for patients who require a little more than a nasal cannula can provide. The mask can provide 5 to 8 liters per minute with an FiO2 of 40 to 60%. It is more predictable but harder for the patient to tolerate. A Hudson mask with reservoir is for the severely hypoxic patient or the first couple of minutes of the patient assessment before you've had time to evaluate the oxygen requirements. This mask can provide a flow of 8 to 15 liters. Because of the reservoir, it can provide an FiO2 of 70 to 95%. A minimum flow of 8 liters per minute is required for this mask, otherwise the patient can empty the bag and decrease the inspiratory volume. When giving oxygen, start out with a high flow and titrate to the patient's needs later. High flow oxygen for prolonged periods can be toxic, but in a critical situation it is better to provide enough oxygen to avoid hypoxia.